Hey class, in this recording we're going to talk about lymphatic organs. And as we look at lymphatic organs, we need to emphasize that to make them an organ, they need to be well defined anatomically speaking. So they're going to have some kind of connective tissue capsule isolating them from the surrounding tissue types. And we can take our lymphatic organs and break them up into primary and secondary categories. As we look at primary lymphatic organs, these are going to be the red bone marrow and the thymus. And these are typically the sites where cells become immunocompetent. I know we haven't talked about that term yet. We'll get to it in a little bit. So where T and B cells become immunocompetent, also known as the ability to recognize and respond to antigens. So that's where our primary lymphatic organs are. Our secondary lymphatic organs are the lymph nodes, tonsils, and spleen. And we'll talk about those as well. And we should mention that in these secondary organs, the lymphocytes don't become immunocompetent, but instead immunocompetent lymphocytes will populate or travel to those tissue types and hang out. So as we look at red bone marrow is primarily going to be located in the spongy bone tissue of our bodies. As adults, overwhelmingly it's going to be located within the spongy bone tissue of our flat bones. But as we look at this right here, we can see that spongy bone tissue in the epiphyses of the femur, we have lots of red bone marrow. And that red bone marrow has a lot of hemopoiesis, or blood formation. And some of the blood that's made is going to be red blood cells or erythrocytes, actually overwhelmingly. But we're also going to have some immunity as well. I like this figure in that it shows some megakaryocytes right here, fragmenting off and having platelets entering the bloodstream from a blood sinusoid. And this blood sinusoid also is showing lots of leukocytes entering into the bloodstream as well at that location. Now this red bone marrow is highly vascular. There's a huge amount of blood vessels in it. And it's going to be separated from the trabeculae of the spongy bone marrow by the endosteum of the bone marrow, or the bone tissue. And as these cell types, which are both the white blood cells, the leukocytes, the erythrocytes, and the thrombocytes, they are going to be pushed into these sinuses. And while they're pushed into the sinuses, eventually they'll work their way back into the circulatory system and get carried around within our bloodstreams. As we look at the thymus, our thymus is shown right here. It's a bilobal organ, so we have left, right lobes, and it's a multifunctional organ. So, a twofer. It's part of both the endocrine and lymphatic immune systems. And as we look at the thymus, this is going to house developing lymphocytes, primarily T lymphocytes, and it's also going to regulate hormones that secrete hormones that regulate lymphocyte development and activity. To find the thymus, we need to look at the superior margin of the mediastinum, wrapped around our trachea, just between the sternum and the aortic arch. And as we age, the thymus involutes. And when we say involute, it means that it gets smaller via degeneration. This involution of the thymus is pretty profound. When we are born, the thymus is the size of our heart. And as we age, the thymus goes from being the size of our heart to being a small mass of shriveled up connective tissue. As we look at our thymus in terms of its histology, we have a photomicrograph right down here for you. And as we look at that photomicrograph, we have a cortex and a medulla to the thymus. In this photomicrograph, the cortex is stained darkly, and the medulla is stained lightly. And then we also are going to have invaginations of the capsule. So we have a capsule, capsular membrane wrapped around the outside. And then there's going to be invaginations of the capsular tissue. We call those invaginations of the capsular tissue a trabeculae. And then these trabeculae, so here's a trabeculae right here. Here's a trabeculae right there. Those trabeculae are going to encompass and differentiate lobes. So I'm circling a lobe of the thymus in yellow. Here's another lobe of the thymus over here being circled in yellow. As we look at our thymus, the cortex of the thymus and the medulla of the thymus are going to have lots of T lymphocytes, T for thymus. The epithelial cells of the thymus are the cells that are going to make the secretions, the endocrine secretions. And as they go off into the cortex, they will secrete thymosin, thymopoietin, thymulin, some interleukins, and some varieties of interferons. We talked about thymosin and thymopoietin previously. Just to review, thymosin is going to stimulate the development of, or the maturation of, white blood cells. And then as we look at thymopoietin, thymopoietin is a hormone that helps to promote the development or the generation of new white blood cells. As we look at our lymph nodes are the single most numerous lymphatic organ. They are going to have a connective tissue capsule around the outside. And as we look at these lymph nodes that are separated by these connective tissue capsules, we find that there's about 450-ish in a typical young adult, and they serve two big functions. They clean and filter the lymphatic fluid, and they help us to activate T and B cells. Not make them immunocompetent, but to activate them, to expose them to the specific antigen they are programmed to respond to. Our lymph nodes are really basically the size of a big kidney bean. For when I've done dissections, cadaver work, those are the sizes that I've typically found them. And as we look at the lymph node, they're very similar to the thymus in that connective tissue capsule is going to form invaginations that are going to form the trabeculae and then divide the interior into compartments. And then as we look at the stroma of the lymph nodes, so the main body of its tissues, the stroma is going to have lots of reticular cells that are going to be secreting reticular fibers to help filter that blood. Something else that's worth emphasizing is with a lymph node, there's always going to be more input vessels, lymphatic vessels, than there are output. There's always going to be more afferent than efferent lymphatic vessels with a typical lymph node. And as we look at that typical lymph node, the reason why we have more afferent vessels leading in than its efferent vessels is because that's going to cause a pressure gradient. That's going to force fluid to slow down and get filtered while it's in here because we have more afferents than efferent lymphatic vessels. So this is a very important structured or function that's determined by its structure. By reducing the amount of output, we're going to make it so that the fluid has to spend a longer time in that lymph node. Now, as we look at the B cells, the cortex and medulla on the inside of our lymph nodes aren't as well defined as I would have preferred. So as we look at the cortex of our lymph nodes is that outer portion, and then the medulla of our lymph node is the inner portion. And unfortunately, from a photomicrograph perspective, personally I struggle with this because that darker staining tissue type that you would just typically associate with the cortex is going to pop up within the medulla again and again and again, which visually makes it a little bit more difficult. We also are going to find that we have a lot of germinal centers. And these germinal centers within our lymph nodes are where the B lymphocytes, the B cells, are going to differentiate into the plasma cells that make our platelets, not platelets, our antibodies or immunoglobulins. Now, as we look at our lymph nodes, one of the reasons why lymph nodes are such a big deal is because they provide an alternative pathway to travel around the body. I remember when I was a younger student, I would always think to myself, why is breast cancer such a big killer? Why do so many people die from breast cancer? And the reason why breast cancer kills so many women in particular isn't because the breast is necessary for life function. I mean, you can have a radical mastectomy and still live a very fulfilling long lifespan. The issue with breast cancer is that the breast tissue has lots of lymph nodes in it. And those lymph nodes, the axillary lymph nodes, extend forward into the breast tissue. So if somebody is going to have breast cancer, those cancerous cells can get into the lymphatic system and rapidly travel throughout the body. Particularly when we think of the fact that these lymphatic cells, or excuse me, these cancerous cells are very, very close to the subclavian veins. And once those cancer cells are drained into the subclavian veins from the lymphatic system, they'll be rapidly spread throughout the rest of the body. As we find lymph nodes that have breast cancer cells within them, those are typically going to be swollen and firm and typically not have any pain associated with them. And after that first lymph node is swollen up with cancerous cells, the cancerous cells tend to move to the next lymph node down the line and downstream until we eventually have the the cancerous cells from the breast making it into the subclavian veins. Traditionally, to treat breast cancer, the traditional approach has been to just cut off as much tissue as possible. And that led to some very disfiguring surgeries being performed on women that had this disease. In more recent history, it's been found that the lumpectomy is much more effective. When performing a lumpectomy, it's really just ectomy for removal of what's being removed, the lump. So when the lumpectomy is performed, we use a radioactive dye to find the tumor, and then the tumor and nearby lymph nodes that have some cancerous cells are all going to be removed. And the lumpectomy is nearly as effective as the radical mastectomy, but causes far, far less damage. And if you take a lumpectomy and pair it with chemotherapy, we have pretty good outcomes if you detect the cancers early or the tumors early on. As we look at our tonsils are another one of the secondary lymphatic organs. Our tonsils are typically going to be defined as patches of lymphatic tissue near the entrance of the pharynx. We have the lingual tonsils, we have the pharyngeal tonsils, and then the adenoids as well. And as we look at these tonsils, our tonsil is going to have large indentations to it. And these large indentations, these really deep skinny indentations, are referred to as tonsillar crypts. These tonsillar crypts are going to allow for pathogens to get embedded down within, and we can sample the pathogens or potential pathogens that are flowing past the tonsils. We find typically that these pathogens that are getting into the tonsillar crypts are going to be ingested and or inhaled from the external environment. And as we look at the tonsils do serve a very important purpose in that they help us to monitor and respond to pathogens that may be getting into our bodies. But if you are an individual that has your tonsils swelling up all the time, you may need to have your tonsils removed. I know for myself in particular, I had issues with tonsillitis when I was a younger child, and it made it very difficult for me to swallow. I was waking up at night frequently because it was hard for me to breathe. So I had a tonsillectomy performed. I had a couple of my tonsils cut out of the back of my pharynx or the back of my throat to help alleviate those negative secondary symptoms. As we look at our tonsils, the palatine tonsils are going to be a pair of tonsils on the posterior margin of the oral cavity, right up here. The lingual tonsils are at the root of our tongue. So the lingual tonsils are medial to the palatine tonsils. The palatine tonsils are lateral to the lingual tonsils. And then our adenoids, aka the pharyngeal tonsils, are going to be up at the superior margin of our nasopharynx, right at the end of our nasal cavity. And then we also have our spleen. As we look at our spleen, the spleen is the single largest lymphatic organ. If you look at mass, there are other lymphatic organs like the lymph nodes that are going to be the largest, but the spleen is the largest individual lymphatic organ. And within our spleen, we have red pulp and white pulp. The red pulp typically is going to be stained bright pink in a photomicrograph and has lots of erythrocytes or red blood cells being stored in it. And as we look at the white pulp, which typically stains a lavender or light purple in a photomicrograph, that white pulp is going to have lots of leukocytes within it, or white blood cells that are being built up and stored in the spleen. So you can think of our spleen as a blood reserve organ. It is going to store extra blood cells so that if we have some kind of vascular trauma or we're bleeding out, the spleen can dump extra cells into our red blood cells into our bodies. As we look at the rupture of spleen, if it's ruptured, we typically need to cut it out right away, a splenectomy. And the problem with a splenectomy is that now we no longer have that reserve of white blood cells that we store in our spleen, or the reserve of erythrocytes that we store in the spleen. So individuals that have splenectomy are going to be immunocompromised individuals after having that surgery done. So here on this photomicrograph, we can see some red pulp. Over here, we can see some white pulp. So you can differentiate them pretty clearly via the color that's associated with them. Also, if you look at nucleus density, the white pulp has a much higher density of nuclei, cell nuclei, than the red pulp, because white blood cells have nuclei and red blood cells do not have nuclei. Our spleen is also going to process red blood cells. Healthy red blood cells or erythrocytes can just go in and go out of the spleen, no problem. But old, broken down red blood cells are going to be aggregated and concentrated in the spleen so that they can be recycled and processed as we remove them from circulation. Our blood cell production begins in our spleen when we are in utero, and we also are going to have red blood cell production in the spleen if we're very anemic. The white pulp of the spleen is the part of the spleen that has the white blood cells, and it's monitoring the blood for anything that doesn't belong, any foreign antigens that may be in our bodies. And if they detect a foreign antigen, they release high numbers of monocytes into the bloodstream. And then finally, our spleen helps to stabilize blood volume by transferring plasma to our lymphatic system so that we can have just a secondary mechanism for maintaining overall fluid volume in our bodies. That's all we have for this recording. If you have any questions or comments, please feel free to post them in the class discussion board. And as always, happy studies.